Hello, welcome to another in our series of digital slide review sign-out sessions with interesting case material from the Digital Pathology Association and PATH presenter. I'm Dr. Louis Hassel, and I'm coming to you from the University of Oklahoma, although my background is from Mesa Verde National Park. Our case today comes from the realm of skin and soft tissue pathology, and is sometimes a challenge that we encounter. It's a shoulder mass around the shoulder girdle in a 45-year-old male, which was detected by both physical exam and then further studied with radiologic studies. So this might be a useful time to just review very briefly some of the imaging modalities that are used in soft tissue lesions and some of their relative advantages and disadvantages. I'm not a radiologist, but from interacting on tumors and so forth and tumor boards and various other settings, I do have a pretty good understanding of what's going on. So ultrasound is particularly useful in defining fluid and solid tissue interfaces, can detect masses of differing density, help to define depth and so forth. When adjuncted with Doppler imaging, it can also be helpful for defining blood flow, vascularity issues, and those kinds of things, which in particular tumors can be especially helpful. CT and CT with contrast, is much more helpful in defining the full anatomy, particularly relative to radiodense lesions like bone and so forth. But with contrast, you can get various phases in terms of the contrast agent following the blood flow, either an early or delayed release of those agents can help to characterize the lesion, particularly carcinomas in some settings like pancreas and so forth, quite well, and is valuable also in defining anatomy for surgical approach and so forth. MRI, of course, avoids the exposure to ionizing radiation and is also quite useful in defining anatomy, particularly relative to fluid content, fatty tissue planes, and those sorts of things. And so is quite useful in soft tissue lesions generally. So just to review what we had with our particular case, as you can see here, is a irregular, variably attenuating lesion, hyperattenuating lesion on MRI here around the shoulder joint, and perhaps extending along tendon lines adjacent to the bone and into, but not maybe not penetrating into these muscle planes, but involved here on the fascia and so forth. So it certainly has a worrisome character in that it's involving multiple areas and spaces, has a heterogeneous MRI signal intensity, and here has a fair degree of fluid associated with it. Now, when the radiologist looks at a lesion like this, there are a variety of things that might come into play, and this is taken from a radiologic discussion on synovial sarcoma, but I think it illustrates the a very wide array of things like, pigmented villonodular synovitis or giant cell tumor of tendon sheath, hemangiomas, neurofibromas, and so forth that also can be confused with lymphoma, undifferentiated pleomorphic sarcoma, myxoid chondrosarcoma, and so forth, which may have variable amounts of fluid and so forth. So that illustrates that, that their differential can oftentimes be much broader than the pathologist's differential as they approach a lesion like this. So we received some biopsy samples, and as you can see here, it's all fairly homogeneous, but some variability in staining without any evident epithelial structures and so forth. Here in this more variegated area, we can see that there's some spindle cell proliferation here, some more pale areas, some more eosinophilic areas, a degree of small, delicate vasculature in the background, and fairly uniform nuclei. quite almost monotonous, you would say, somewhat rounded to oval, but occasionally sort of spindle-shaped cells here. So this certainly falls into the differential of a spindle cell lesion, relatively low grade, and so forth. So when we think about spindle cell lesions that have this relatively monotonous appearance, we're thinking about sarcomas as a possibility, but there may be other things that enter into the differential considerations. I think in the very broadest array of spindle cell lesions, there are benign entities like nodular fasciitis or schwannoma that come into the consideration, but there are also more aggressive, sort of intermediate stage things like solitary fibrous tumor, low-grade fibromyxoid sarcoma, DFSP, and so forth, and then a few more aggressive malignancies like synovial sarcoma, malignant peripheral nerve sheath tumor, or leiomyosarcomas. So that's a very broad differential to be considered in a diagnosis of this setting. Of course, there can be other benign and malignant lesions that have even focally spindle cell appearance. What's notable is that many of these more monotonous spindle cell lesions tend to have a fusion gene, translocation or something of that sort. And that's true both in the more benign lesions like nodular fasciitis and tenosynovial giant cell tumor, as well as the more aggressive and frankly aggressive malignant lesions where fusion partners with ALK, fusion partners with EWSR1, and other lesions can enter into the differential. So this poses a little bit of an issue in terms of what do we do in evaluating these from a pathological workup standpoint. Do we just jump to do a fusion gene panel of FISH testing or other sort of sarcoma panel? And in fact, such things are available from certain providers, but I think most of us would generally go to some sort of an immunohistochemical panel. And that might include various things like, let's see if I go back here. Well, I don't think I have the correct panel here. Let me see if the next slide has it. So that can include a variety of immunohistochemical tests that we might consider in looking at this panel of lesions. So we might do a CD34, we might do a STAT6, since that's the partner here. We might do an NTRK. We might do an ALK stain. We can certainly do smooth muscle and calponin and those sorts of markers, Desmin. And we can do other markers like CD99, which may not be totally specific, but certainly restrict the workup to some degree. Now, if we do get to the stage where we're kind of confirmed or feeling like we've got it narrowed down, then you can do a more selective panel of fusion gene markers, such as this marker for SS18. Now, this fusion marker is usually a break-apart gene in FISH testing, but as you can see in this panel, the signals are not separating. The red and the green are not separated here. So what's going on? Well, in fact, there are some circumstances where the translocation is so close that you're getting the fusion gene protein expressed as seen here on immunohistochemistry, but it's not evident in the break-apart testing. And so sometimes you've got to actually do both. You can't get away with just doing the FISH testing because there will be some circumstances where you will have the fusion protein, you'll have the morphology, but you will not have the definitive separation of the break-apart gene on fusion or FISH testing. So in our particular case, observed SS18, SSX fusion protein, giving us then the diagnosis of synovial sarcoma. Now, synovial sarcomas are typically identified in the adult age group, but they do have a very broad age range. They can occur in a variety of locations, both in the trunk, both superficially and in deep locations, and in the extremities. They're, in contrast to their name, they're not derived from any particular synovial cell that we've identified, but they do have this characteristic fusion gene. Now, most commonly, they're biphasic tumor, which has an epithelial component. And that's very helpful in the differential considerations, because if you can identify a cytokeratin positive area or an EMA positive area and a sort of characteristic glandular or pseudoglandular formation, that is virtually diagnostic. There's hardly any other tumor that will give you that appearance. But in our particular case, we did not have that. And so the identification of the fusion gene proteins and so forth was very helpful in arriving at the diagnosis of synovial sarcoma. Now, to jump back to our histology, just to review here, the features that we would find useful are this very delicate vasculature in the background, the fairly monotonous and low-grade appearing morphology. This is not a high-grade pleomorphic type of sarcoma, and a modest proliferation rate, but it's not overwhelming. Mitoses, if you were to search for this, might not be terribly prominent. Now, in some circumstances, the cellularity can vary, and particularly around vessels, it may tend to become less cellular around those areas and sort of taper out into the other areas. So that gives you an idea of the morphology. I've included one other example in the digital slides related to this tumor, and that will be available for your study afterwards. So our final sign-out diagnosis on this case was monophasic synovial sarcoma, and that is the summary for today. So thank you so much for joining me. If you enjoyed this, you know the drill. Hit the like, subscribe. We always welcome to have additional subscribers, and we do intend to continue to release interesting and challenging cases from time to time. Now, I didn't include the immunohistochemistry workup that we would typically include. I'll post that in the comments so that you can refer to that later as well. So until next time, thanks so much for joining me.